Good evening. Welcome to the Bessie Smith Cultural Center. This is our third series of our African American history program on Thursday night. This is the third one, and this one I am certainly hoping that we can sit down and enjoy this evening together. We're live streaming, okay? And I apologize. I'm hoping that we have others to come in. Certainly, I talked to Dr. Mance. He told me, don't worry about the weather. Everything will be all right. And it looks like it's going to be all right. Dr. Mance knows somebody, I guess. Anyway, thank you. My name is Elijah Cameron. I'm Director of Community Relations for the Bessie Smith Cultural Center and the Chattanooga African American Museum. We have tried to put on some programs this February that would be what we thought was interesting to the African American community and the community as a whole. One of the things that we talked about when we were looking at putting on these programs was being able to bring in physicians to talk about the disparity in the healthcare here in Chattanooga. And of course, I can't say the rest of the world, but I know about the disparities here. So we wanted to bring those professionals in who see it on an everyday basis and have them to talk about these things as we move forward in our community. I'm going to introduce Ms. Paula Wilkes because she has a special presentation she'd like to do before I go into my little spiel and then turn it over to Dr. Mance. Okay. You can. That'll be fine.
Okay. First, I'd like to welcome you all as well. Little housekeeping. Restrooms are straight through the doors and back on your left. We'd like to thank our sponsors, Erlanger Health System, City of Chattanooga, and Tennessee Arts Commission. They've made our Black History Month programs possible for us this year, so we're very glad to have them on as sponsors. But tonight I want to recognize what we're calling our Member of the Month. We have multiple members of the museum, but we have one member that shows up for all of our events, all of our festivals, all of our talks, everything. And so I'd just like to recognize Ms. Waynetta McDowell tonight. And I've got a little something for you, Waynetta, so come up here. Waynetta is a historian in her own right. She can tell you stories of Chattanooga history, Howard, Riverside, everything. So we love our friend Waynetta, and so tonight we just want to give you and honor you as our Member of the Month and give you a little gift.
Waynetta was one of my classmates. In the late 60s and 70s, community health centers started to come online across the country. These centers were designed to focus primarily on the medical underserved and uninsured. The health centers accepted Medicare, Medicaid, and commercial insurance. Care was provided to all persons without regard to ability to pay, dealing with the sliding fee scale. In Chattanooga, the community health centers were started in 1968 with the establishment of the Alden Park Neighborhood Health Centers, now Southside. In 1976, the health center expanded to the east side of the city with the establishment of the Dodson Avenue Health Centers. We have always known that there was disparities, was and is a disparity in healthcare in Chattanooga. It has been said that Chattanooga is actually two cities when it comes to healthcare. With the onset of health centers, there was an influx of new young doctors coming into the city, doctors that looked like the communities they serve. New educational programs started to come online, hypertension classes, diabetic classes, infant mortality rate classes. Nurses and social workers that went into the homes to talk with patients about their health needs and giving them encouragement to keep their appointments with their providers. Some of these physicians here today were a part of all that. I worked with some of these physicians out at Alden Park Health Center and Dodson Avenue Health Center back in the day. And I tell you, it did make a change in the community and those that we were serving. Before the health centers, there were those pioneer African-American physicians who pushed for changes in the delivery of health care to the African-American community. Physicians like Dr. Levi Patton, Dr. Lonnie Boaz, Dr. Joyce Taylor, and of course, Dr. Hyman Moore. These physicians were able to do a lot with a little, and at times when they weren't always received in the best light by their white peers and sometimes even their African American patients. These were the forerunners for the physicians we have today. And while the struggles continues today to eliminate the disparity in healthcare, we rest assured that there are well-educated, confident, passionate African American physicians trained in every facet of modern healthcare: primary care provider, cardiologist, neonatal, gastroenterologists, x-ray, pediatrics, and also administrators, and so on. And we welcome them. We're really excited about what we see in our physicians today, because we know they care about the people that they serve. And not only do they care about the people they serve, they care about the community they serve in. So we welcome them. And tonight, we have a few of those physicians with us to talk about their profession and the type of disparities that they see and how they see healthcare in our city today. I want to welcome these physicians here. Dr. Mance will introduce them. And in the event that there are questions, that this mic will be right there, and you can ask questions, and I'm sure these physicians will be able to answer them. And if they can't, there are physicians in the audience that will help them. Thank you and welcome, Dr. Mance.
Thank you and welcome tonight. When we did a meeting here, a meet and greet about 2 months ago, Mr. Cameron asked me, would I be willing to do a health talk or have a panel that can talk about healthcare disparities in Chattanooga? And I told him, I said, we'll be happy to do so. And what happened to us is that, as I was talking before we started tonight, I said many times there are things that take place in the background that many people may do not realize their biases or the things that they're doing that may not necessarily be correct. Because, and a classic example, a person in the emergency room seeing hundreds of patients per night, and all of a sudden have a bad experience, and what happened? They began to stereotype some other patients that we don't necessarily do so. And so what happened to us, we have to be very vigilant to basically constantly keeping ourselves in tune to what is best for each person or each patient, and also how to deal appropriately with each family members. And what happened to us, once a word is said or a deed is done, it can't be taken back. And so one of the things that we want to talk tonight about healthcare disparities, and I have a distinguished panel. Dr. Tanya Love, she is an internist. Presently, she's working at Partridge Hospital. She is specially trained in internal medicine, and she has received great accolades with respect to her wellness career in this city and around the country, where she has participated with many organizations and been asked to be leader. We also have Dr. Spencer. Dr. Spencer is a board-certified pediatrician and also neonatologist. And I asked her, so what's a neonatologist? She says, what?
Baby ICU doctor.
A baby ICU doctor. So it's very simple. Also, to my right, we have a young lady who basically is specially trained in surgery, but also in oncology, breast surgeon, which she is super trained. And all the patients that I've heard, who have seen her, has given her great accolades because of her kindness and her wealth of knowledge and her results from surgery. Also, to my far left is my old colleague, Dr. McCoy. I've known him for almost 40 years, in which, 30 years. I'll make him younger. But what happened is that he is an excellent cardiologist. He's specially trained. He is the first board-certified cardiologist, African-American cardiologist here in Chattanooga. And basically, he is super trained, and also he has a great caring manner about him. And when I see a lot of his patients, I always tell them, if you don't watch out, he be praying over you. And and they kind of laugh, and it says, I like that. And so what happened to us, we have people who have great reputation, who has a reputation that no one can question. Well, my name is Cornelius Mance. I'm a neurologist. I've been here, this is my second coming in 1983. My first coming was 1975 to 77, which I trained at internal medicine at Erlanger. Then I went back to Memphis and did neurology, and I moved here in November of 83. And so basically I've been practicing neurology ever since. But one of the things we want to talk about is healthcare disparity. Many times we have a tendency to think about health and healthcare disparities. When people think about health disparities, that's basically given to a group of people who basically do not receive adequate care. But when you're dealing with healthcare disparity, it refers to the difference between groups of health coverage, secondary to access to care, quality of care, and it may be segregated or differentiated by socioeconomic status, age, location, that means geography, your gender, disability, and sexual orientation. And as we see today, many of the decisions that is coming down from the political state is basically really dealing with sexual orientation in which people receive inadequate care. What happened to us is that we have to remember is that if you think about healthcare disparity associated with Hispanics, Asians, and African Americans, that is affecting 30% of the cost of medicine. And that cost equal to $309 billion per year of excess costs, but also increased suffering. So what happened to us is that just imagine if we basically begin to become more aware of the healthcare disparity that's been put upon us, we could basically be able to have much better improvement in our healthcare system and have extra money to do a lot of things. And the barriers that are associated with healthcare disparity, one, is not invited to participate due to unconscious bias based on racial stereotype and structural racism. Two, lack of trials awareness to access due to location. There are many places where you don't have a hospital or have a doctor, and you basically cannot get there. The other one is concern about the risk to employment or to legal issues. Many patients will not seek certain care because they're afraid they may get arrested or there may be some legalities. And that's one of the things we hear on the news all the time. Socioeconomic status and education. Many of us, we are not educated, or we do not receive information. We do not have advocates that basically can go out and get information to you, but also get credible information, not information that is biased. And I always tell people, if you have someone who has given you credible information for years and years and years that have not been political, they've always been straight shooters, listen to their advice because they have your best interests at heart. Another one is financial and logistic burden on patients. Many patients do not have the money, or they do not think they have the money. They may have a hard time getting certain things done. One of the ones that I find that we think about that we probably don't think about, people have mistrust of research because these researchers and sponsors do not include majority, they choose mostly minority group. And what happens is that if they do not have adequate representation of the minority group, because their biology can be different, you are basically making a recommendation that do not necessarily meet the benefit for those groups. And the last one is restriction and exclusion criteria. And that's one of the things that happens right now. Almost everyone in here, if you have needed some medication that wasn't generic, your insurance company would tell you, well, you need to take generic before you can get the name brand. Even though you've been on the name brand for the last 5 years and had great results, they still want you to go through a generic, which may not be of the same quality. And so what happened to us that we have to just remember is that the burden of healthcare disparities is in our hands, and we must work to educate patients, also to educate groups, but also be able to communicate to professionals or the politicians for them to make better decisions, because most of them are making decisions not in the best interest of the patient. So what I will start tonight, we will have a presentation from Dr. Spencer, and she will talk about healthcare disparities dealing with the little ones.
Mm-hmm. Thank you, Dr. Mance. So I would talk about some healthcare disparities as it pertains to Black women and infants. As Dr. Mance stated earlier, I'm Dr. Michelle Spencer. I'm one of the neonatologist, baby intensive care doctors at Erlanger. And my colleague, Dr. Stephanie Holt, and I are actually the first Black doctors to work in the neonatal intensive care unit at Erlanger. And we're happy to serve the community. So when I get into the topic, it's definitely one that I'm quite passionate about, and it begs the question for us to start with the definition of what health disparities are. Health disparities are persistent, avoidable, and therefore unfair health differences between socially advantaged and socially disadvantaged groups. Why is this important? The COVID-19 pandemic held up a magnifying glass to the long-standing racial inequities in American health care. In this country, Black people died from COVID-19 at 2 times the rate of white people. The pandemic exposed America's long history of inequitable medical treatment of Black patients and its legacy for broken trust. Amongst the Black community, there remains a mistrust of the healthcare system. One of the stories that stood out to me the most was the story of Dr. Susan Moore. Dr. Moore battled COVID-19 in December 2019. I vividly recall seeing the video she posted to Facebook as she documented her fight for fair medical treatment. She stated, "You have to show proof that you have something wrong with you in order to get the medicine. I put forth and I maintain, if I was white, I would not have to go through that." As she explained her interaction with the physician caring for her, she stated, "I was crushed. He made me feel like I was a drug addict, and he knew I was a physician." Days after she was initially discharged, Dr. Moore died from coronavirus complications. She was just 52 years old. The Indiana University Health Hospital System denied mistreatment in her case. We're going to discuss some disparity among Black mothers. And so there are stark racial disparities that exist in maternal and infant health in the United States. According to the Center for Disease Control and Prevention, CDC, 25,000 women develop severe birth-related complications. 700 women die giving birth every year. 2/3 of those are considered preventable. And Black women are 2 to 3 times more likely to die from pregnancy-related causes. Maternal mortality is the death of a woman while pregnant or within 42 days of the end of her pregnancy. More than 50% of pregnancy-related deaths in the United States occur after the birth of the child, so that's in the postpartum period. Postpartum cardiomyopathy, a form of heart failure, and blood pressure disorders, preeclampsia and eclampsia, are the leading causes of maternal death for Black women. The disparity in maternal mortality between Black people and everyone else is one of the most clear signs that structural racism exists. It has been determined that one of the root causes of this inequity is failure of communication and teamwork among the staff caring for Black women. What that looks like in particular is when Black women express concerns about the way they are feeling, particularly around pain, the healthcare system is slower to respond. It is unfortunate, but there are still some that believe Black people have a different pain threshold than other races. Some people attempt to attribute black-white disparity in mental health outcomes solely to lower socioeconomic status. This, however, is not the explanation. A recent study showed that wealthiest black moms are more likely to die in childbirth than the poorest white moms. The study conducted by Rosen Slater and her colleagues, Dr. Petra Pessin, used California administrative data to show the first time that household income plays absolutely no role in determining maternal-infant health outcomes. In fact, the effects caused by structural racism are so strong that even the wealthiest black women and their newborns experience the worst outcomes than those from the lowest income white families. In other words, the maternal health gap is a trap of systemic racism with roots so deep that no amount of money can buy a black woman's path out of it. We'll transition to the disparity that I more commonly see in the neonatal intensive care unit, so the disparity that affects black infants. Higher rates of premature births and low birth weight among black infants are known. African American women while pregnant, do report more stressors and great emotional distress than other pregnant women of different racial and ethnic groups, which could be a contributing factor that could explain the higher prematurity rates that we see and the lower birth weight in babies that we see. Infant death rates are higher in hospitals where the very low birth weight babies are black. Black infants have twofold greater risk of dying from prematurity-related brain bleeds, intraventricular hemorrhage than white infants. Complex racial and/or ethnic disparities in structure, process, and outcome measures often disadvantage infants of color, especially African American infants. In a study conducted by Marion McDormand of the Maryland Population Research Center at the University of Maryland, they found that black newborns in hospital death rate was 1/3 lower when black newborns were cared for by black physicians rather than white physicians. Why does healthcare disparity still occur? One writer stated, "As much as we try and keep clinicians in high esteem, they mirror our community. There is still a lot of inherent racism and bias." In the book Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, they discussed racial bias in medicine, noting that U.S. healthcare providers see black patients as less personally responsible for their health, black patients are more likely to be blamed for their health outcomes, and black patients are less likely to receive appropriate pain management for the same diagnosis, say back pain, in the emergency room. What can be done about these healthcare disparities? Because we always have to say there is hope in every situation. So closing the gap for black-white disparities in maternal mortality involves addressing structural racism, that is, those aspects of social, political, economic, and healthcare systems that reinforce inequity. What is being done now? As all of us can understand, representation matters. More black doctors in healthcare is important. Nationwide, black doctors make up 5.3% of all practicing physicians, while the 2020 census estimates that blacks are 14.2% of the total population. We need more black doctors. Having a seat at the table changes the discussion, and I've seen that personally. Finding a black doctor is a start, but it doesn't stop there. What can you do to be a more empowered patient? Because that's the important thing. While things and policies are happening, we're still existing in an environment that has these biases. So how do we protect ourselves? I read a statement that resonated with me. Whether she is a mother or not, a black woman's ability to navigate a healthcare system that is stacked against her is crucial, not only for her own well-being, but for those around her. It is too often on black women to push to get equal treatment by healthcare systems. There is work to be done on both structural and individual levels by all people to make healthcare more equitable. But as that work is being done, here are some effective ways black women can advocate for themselves and their loved ones. I like to call it tips to help navigate the healthcare system. Be your own advocate. And being your own advocate doesn't mean like you have to be arguing with the team all the time. It just means feeling that you can speak up on your own behalf. I read an article that divided this down into 7 tips, and I thought they were quite helpful and are things that I usually tell my patients, or the parents of my patients, because my patients don't talk yet, but the parents of my patients when I'm trying to tell them how to advocate for themselves. So do some research. Before you go in, look up Google. We call it Dr. Google amongst doctors because patients come in very strongly, with the Dr. Google diagnosis and stuff. But look it up and see what questions you could have in advance, because that will help you as you're navigating. Ask plenty of questions. Some of the questions could include, is there anything that you would want me to ask that I'm not asking? Or, do you feel comfortable treating my case? If not, should I be referred to a specialist? So that's a really good one. And be prepared to be honest with your answers, as honest as you can. And then make sure you're comfortable with your provider. And that doesn't only mean that the provider looks like you, but a provider that makes you feel comfortable. You know what makes you feel comfortable. So if that is finding a provider that you feel comfortable with, the National Medical Association does have a list that you can search for a provider that fits you. Bring someone with you because, as we know, family members will always advocate for us and they can ask questions that we might have forgotten. Don't leave empty-handed. Get a pamphlet because sometimes as the information is coming to you, all the medical jargon, you could mix what they're saying, but if you have a pamphlet, later you can read over it and then you can go back and ask questions specific to what you've read if there's discrepancies. And then keep speaking up. Another thing I let patients know is how to escalate if there's something that's not being addressed. So the nurse manager is always a good person to ask for. If you're in an inpatient setting, asking for a medical director next, a patient advocate are different ways to get things addressed if it's not being immediately addressed.
Thank you.
You're welcome.
Dr. Love?
Good evening. My name is Dr. Love, and I'm a hospitalist at Park Ridge Medical Center. And to ditto the neonatologist here tonight, you deal with babies and families. I deal with the adult population. And when I think about this is cardiovascular disease month, and what is the #1 killer is heart disease. And it affects us even more as African-American women and men, and we die more and have higher mortality and injury rate because of the disease. We add diabetes in there, and we add hypertension in there as well that put us at risk more for cardiovascular disease. And when I think about the healthcare disparities, coming from a perspective from being a critical care nurse, a nurse practitioner, and a physician, and having those experiences of what inhibits and what are the barriers to our patients, and access, education, communication, access, and access. Access, the inability to a physician that looks like me, access to a physician who understands and really care about me, and again, access, the ability to be in a facility or a place or a space or a doctor's office that understands and care about me. When we think about the statistics that was just previously stated, you tie that over to the adult population. You tie that over to other barriers that what limits us, what keeps us from thriving and being treated equitable, not in just the areas from a financial standpoint, not in just the areas of food, not in just the areas, so the social determinants of health go on and on and on. And so when I think about that, I think about the scenarios that plays in my head, what has inhibited or been barriers to the patient getting good care, the patient understanding when he or she went home, the education and teaching they got because of our implicit biases. We're talking about equality, and there's a difference between being equity and disparity. And I thank you for pointing that out so people can know the difference and understand where we are with diseases and just in life in general. And so when we think about heart disease again, we think about diabetes, we think about high blood pressure. We can even add cancer in there because we are at increased risk because of access again. As a physician, trying to navigate being a nurse prior to what can I do to educate not only my patients, but educate the families to be an advocate for those patients while they're in the hospital, because they hear different things, they see different things, and it doesn't always register at that time. And so access, having an advocate, I don't care if it's a neighbor, to advocate for their health, to decrease the risk and the disparities when it comes to health care. When it comes to being in Chattanooga, it's a different setting. I've been different places, traveled different places and spaces, and we've come a long way, and I'm sure Dr. Mance and all the other physicians can speak to this. We have a long way to go. Inclusiveness is very important. Do we include our African American physicians with our Caucasian counterparts to be inclusive, where we can have a dialogue to how do we better take care of our patients? How do we better have respect for each other as colleagues, because all that tends to trickle down, not from just the physician, it trickles down to the patient and it impacts care. Trying to be an advocate, not only as a physician, but also a patient myself. And we can go through scenarios of being a patient, knowing that I am a physician and was a nurse, and the nurse did not listen to me because he had already had his implicit biases. So we're here today to navigate, to change the narrative and the dialogue and come together and have the understanding to really define disparities, to really define what equities are, and really do something about it. We still have a long way to go. I'll continue to do my part and do what I can to navigate in this community, because there again, this is my community. I was born and raised in this community, and I saw the things and the impact of lack of access, lack of physicians that look like me, lack of a compassionate, caring attitude, and trying to understand those patients and not call them non-compliant because we wrote a prescription that they could not afford. And we think about Maslow hierarchy of needs. You're going to do food, clothing, and shelter before anything else to survive. And so that's just my talk on disparity and equity, Dr. Mance.
Thank you. Dr. Williams.
Hello, everyone. I'm Dr. Tequila Williams, and I'm with CHI Memorial Breast Care Associates, and I am one of 2 fellowship-trained breast surgical oncologists in Chattanooga and the surrounding area. And just to echo what most people on this panel, most of the physicians on this panel will talk about tonight, is when we talk about breast cancer, there again is not exempt from these disparities that we're seeing across all disciplines of medicine. And so, I always say, one of the ways that we can try to help close this disparity is that we have to do a lot more education. We have to do talks like this. We have to make ourselves available to our community so that they can see our faces and that they know that we're here and that we're here to help take care of them. And so I always start by a little bit of education. And so, when I talk about breast cancer, I always say, look around the room. And if you count the women in this room, 1 in 8 of us will develop breast cancer over our lifetime. And, even though that seems like maybe a small number, when we look at and we divide that amongst our Caucasian counterparts and our minorities, in particular Black women, we are dying disproportionately when we talk about breast cancer. We're also being diagnosed at a lot earlier ages. So our median age for development of a breast cancer for a white woman is 62 versus 58 for a Black woman. And so you can see there that not only are we being diagnosed earlier, but also we are being diagnosed with more aggressive types of cancer. And so just like Dr. Mance mentioned earlier, when we do these trials, when we do studies, Black people, because of our medical distrust in the medical community and a lot of other factors, we're not always a part of these studies. And so when we're recommending trials and these new novel treatments, it's not people that look like us mostly in those trials. And so we, even though we're doing these medications and for a lot of us it will help, we do see that there's a subset of women, and that's why we're also dying disproportionately, that these medications are not working for, and it's not working as well as our white counterparts. And so as a breast surgical oncologist, we also have to figure out how can we get, because a lot of our stuff is access to care. And so it's easy to say, hey, go get your mammogram every year. But what about that single mother that is trying to raise 3 kids, working 3 jobs? How is she going to fit time in to go get a mammogram? And so even though it's easy for us all to say, oh, just get in your car and go get a mammogram, a lot of what I do also may be access to care. As women, We are caregivers to everybody around us. And so it's easy for us to put ourselves on the back burner, i.e. Black women come in with more advanced stage breast cancers. And of course, if you come in with an advanced stage breast cancer, your mortality is going to be higher. And so at that point, we also have to say education is a big part of what all of us do. And as far as the community, again, we have to make ourselves available. We have to do talks like this so that people can see that we're in this community and that we're here to help. Again, research. I do try to push that, that we need to be in these clinical trials. Our faces and our molecular biology need to be, it needs to be studied because, again, I see things that work well for our white patients and then for Black people, it just does not work very well. And so that's something that we all have to kind of work on to try to push our patients to be a part of these trials. And there's, unfortunately, there's not many, as related to breast cancer, there's not many trials in Chattanooga, but it's still our job to say, hey, you can go to Knoxville, you can go to Nashville, hey, be a part of this trial, especially if you're not having a good response to the treatments that we're doing here. And I find that people are more likely to do that, and our patients, our Black patients are more likely to do that if I'm telling them that versus someone that doesn't look like them. And so it really is important. If you can, not everybody is not afforded the ability to see a doctor that looks like them, but it really is important to have a relationship with a doctor that looks like you. For some, innate reason, we're able to sympathize more, we're able to understand your complaints. And as a breast surgeon, I have patients come in all the time and they say, hey, maybe my medical oncologist didn't listen to the fact that I'm having bone pain or the fact that, I'm having hot flashes and I can't sleep at night and I'm very fatigued. And so what does that turn into? They stop their medications. And when they stop their medications and they don't finish their treatments, that means that they're going to be at a higher risk of having a recurrence. And not only that, they're going to be at a higher risk of mortality. And so, again, we have to educate not only the community, but we also, like Dr. Love said, we have to educate our white counterparts as well. That I have, plenty of white counterparts that I, don't think that inadvertently, that they are racist, but like you said, there are these inadvertent, unconscious biases that we have to educate them on as well.
Oh. Dr. McCoy?
Okay. I'm going to start this off with a case study. I think it would be important to evaluate the patient. 62-year-old white male with a history of hypertension, smoker, has a prior history of having coronary artery bypass grafting. He starts to have chest pain about 12 o'clock midnight. Subsequently, comes in and has a heart attack, but he only gets to the hospital at 9 o'clock a.m. So he's evaluated in the emergency room. His blood pressure is 90 systolic. He's short of breath. His chest x-ray shows pulmonary edema, and now he has got ST elevation in the anterior leads. So the cardiologist is called, and the rapid response team is initiated. The cath team is brought in, and we start on the mission of performing urgent cardiac catheterization and possible PCI on him. The patient goes to the cardiac catheterization lab, and sure enough, his grafts are open, but his LAD is closed, and his graft to the LAD is down. Now we have we have to put a balloon pump in him because of his blood pressure, and now we do the PCI. He gets the stent in his LAD, successful, but he's still got a balloon pump. Now he has to go to the ICU. He's in the ICU for 2 to 3 days, being treated for pulmonary edema, and subsequently got treated with diuretics, pressors. He had at least a 7-day stay in the ICU. Comes out of the ICU, goes to the floor, and now he's treated by nursing staff, physical therapy, and that sort of thing. He gets put on medical therapy. Within 3 days after being on the floor, he goes home. He's on medications, including Plavix, aspirin, a bunch of medicines that cost a lot of money. And his family are not a wealthy group of people. So what we have here is a person post-intervention who had a rough go with intra-aortic balloon pump, pulmonary edema to speak of, and his heart muscle is down. How did this man in this day and time get to reach the cath lab only by 11 o'clock when he started at 12? Time is muscle. Time is muscle in cardiac catheterization and urgent PCI. The only way you can improve your prognosis is to be able to be alerted, know what you're dealing with, and then take the patient to the cath lab for urgent revascularization or opening of an artery. The concerns here are this: the education being given to that patient initially, the disparity of what that patient knew, the issue of how that patient potentially was treated even in an EMS situation. We look to that very carefully now. Patient having chest pain to door and then door to balloon times to dictate what we do for patients arriving with acute interventions. And they really make a difference. They make a difference in your life term, and what you're treated with thereafter, what costs you so much money. So I say that to say this. Over time, I've learned that Afro-Americans have trouble in terms of getting the information, the disparity of being treated so long before we can get the vessel open. It has become such an issue that we created committees to determine who's getting what, how they're getting what, and what's the timing. So I would urge for more education with regards to particular people having acute MIs, people having urgent revascularization strategies, particularly in this population. And when I brought this up before, even at Erlanger when I was there, and Park Ridge, things have changed over the years. When we used to do urgent PCI, it seemed like the new thing, the new kid on the block, doing it right, getting it done. But now, there's not much care about getting black patients to the hospital. And I'm still interested in that as an interventionist, to make sure we get the proper care, the proper decision-making to get the patient to the hospital for revascularization. So in that term, we've created committees, and hopefully over the next few years, we'll repopulate those committees with Afro-American cardiologists who are interested in intervention. My second part of it is, when those patients go on, and my colleagues can affect to that, it was back in my day, the old days, the 40 years, Cornelius?
Yeah, 40 years ago.
Before a patient went home, you had to make sure you called the discharging, receiving primary care doctor before you let that patient go home. Very rarely now do hospitalists call the primary care physician these days, so there's no communication. And you ought to be aware of that, because that makes a difference. Because when those patients arrive in the primary care physician's office, sometimes they're without discharge summaries, they're without knowledge of what those patients are on, decision-making they know nothing of, and when you have to spend probably an hour revoking that patient's admission and what to do next, a primary care physician is at loss, and it stands to be changed. And how we navigate that connection is going to mean a whole lot of importance to those particular patients and those families. You should see us digging for information, trying to take care of those patients. I want to, before, I wasn't going to do the patient care consideration, but let's talk about medications and medications with regards to cardiac patients. You're talking about going from probably minimal money to pay for their medicines, and now you're talking about putting on top 7 drugs in that type of patient who has heart failure and now has a coronary stent in. That's a totally different model for that particular patient, and we need to be very careful how we judge those patients about how, when they come back, whether they can pay for their medicines or not, and how we as physicians talk to them with regards to being respectful, helpful, getting these, caring about how we use our politics to get them freeable medicines that don't cost as much. We use that very happily in my office, trying to get these people in the right medicines for less price. You have to take time. You have to make a decision. These patients need to be cared for. That has to be a commitment by your office. Let me go through some real quick scenarios about the education of cardiovascular health in Afro-Americans. It is intended to educate physicians and population about the approach. The disease prevention in Afro-Americans have had poor overall CV health compared with non-Hispanic Afro-Americans. We live 3.4 years shorter than whites, from an age of 75.5 versus 78.9 years. Cardiovascular mortality made up of 30% of the excess. In other words, the heart disease is the killer with regards to Afro-Americans. No difference in the coronary artery disease mortality between Afro-Americans and whites. That is, people who have CAD die at the same rate that people, Afro-Americans as well as whites. There's a higher rate of fatal CADs compared with whites, meaning when people have heart attacks, their intention of having shock or having issues associated with arrhythmias are much higher than in patients who are white. Meaning, most of that comes from their limitations of making it to the hospital. And most of those pump dysfunction issues come with the fact that they are so long in making it to the hospital. Sudden cardiac death and cardiac arrest, higher in Afro-Americans, more significant traditional risk factors, including sickle cell trait. Sudden cardiac death also occurs in 6 years younger patients than it does in white patients. Less likely to survive at discharge as well. Other info here. Let's talk hypertension for 1 second. Hypertension causes about 12% higher rates than non-Hispanic whites and Mexican Americans. The adult differences begin in youth. Systolic blood pressures level 3 times the magnitude higher than in whites. 10 millimeter mercury increase in systolic blood pressure accounts for 8% increase in strokes in whites, but a 24% increase in blacks. You get that? If you go up 10 millimeters of mercury in blood pressure, your chance of having a stroke as a black person is 3 times more. It's more common in young Afro-Americans. It's higher obesity rates than Afro-American. Something we can do about. Diabetes is more common. The obesity rates occur sometimes due to cultural attitudes of favor, meaning a larger body size, particularly in women. Y'all know what that means, don't you? Higher fat meals, deep frying, cooking, excess calories and salt, decreases in leisure time, and physical activity occur in the black population. Lipids, dyslipidemia in Afro-Americans, underestimated in cardiovascular disease risk in Afro-Americans and younger patients. Under treatment with statins needs special attention by providers and increased adherence. Meaning, we really don't do well in utilizing statins and lipid profile in Afro-Americans just by virtue of their presence and by virtue of their knowledge. That needs to be fixed. Guidelines for pharmacologic management in cardiovascular disease in Afro-Americans generally don't differ from other race or ethnic groups, but there are two issues I want to talk to you about, that there are major differences have been found for Afro-Americans in treatment in cardiovascular disease, namely heart failure with reduced ejection fraction and hypertension. We know that in patients with heart failure, class 3 and class 4 heart failure, treatment with hydralazine and isodil, dinitrate in combination with beta blockers and spironolactone are our best treatment sources for Afro-Americans, particularly if you've got chronic kidney disease. Remember that, hydralazine and isodil, and not ACE inhibitors. Hypertensive Americans are better treated with calcium blockers and diuretics, accepting ACE inhibitors in patients who have proteinuria and kidney disease. So what this knowledge is telling us is when you go to the doctor and you've been treated for hypertension, make sure you go over the fact with them, what are the best drugs for Afro-American who have your disease subset? Be there, be careful, be knowledgeable, talk to them about the issues associated with this disease, and then talking about what the caveats are for Afro-Americans. But last but not least, how do we overcome? How do we overcome this barrier? Better with nutrition, education, disease prevention, connection between primary care doctors, specialists, hospitalists, early detection of disease prevention by healthcare professionals, and then last but not least, combining genomic and phenotypic info, meaning the DNA that we have, does that mean anything with regards to our risk factors, and how do we carry that forward? Thank you. God bless you all.
Just as wrapping up concerning disparities, healthcare disparities includes these 6 things: mortality, life expectancy, burden of disease, mental health, which I think most of us have just kind of don't think about, that over 30 to 50% of the kids have mental problems from head trauma or psychosocial issues, which is affecting them. Uninsured or underinsured, and lack of access to care. And one of the things that happens, if you think about these 6 things, if we attack them and understand them, we'll be more likely to respond. The 3 keys that drive health inequity: social inequities, institutional inequities, living condition, and downstream effect or upstream effect. And what happened to us, communication is very important. I find many times for us is that we as physicians, in this day and age, you find a patient has a problem, the doctor talks to the nurse and make an appointment for him to see this specialist, and they call the specialist office and they say, we can see you June of this year. Okay, I said, if you got a problem, you'd be dead by that time. Okay? So what happened to us many times for us is all it takes for us to do is call that specialist or call Dr. Williams. Okay? And automatically what happens, call Dr. McCoy. The patient gets seen and gets taken care of. That's called communication. But also, it's called respect for that specialist. And that specialist, in turn, will reciprocate. And many times for us is that we don't take the time to do that. And that's one of the things that we have to realize is that everyone wants to feel respected and appreciated. So one of the things I was going to talk about, got men in the audience. What I'm going to talk about?
Prostate cancer.
I'm going to talk about prostate cancer, okay? I told him, I said, I'll tell my story. And what happened is that prostate cancer is the second leading cause of death to men past lung cancer. And what happens is that 30,000 people are going to die from it, in which they found out people who has prostate cancer versus non-prostate cancer people, there's about a 2-year difference in their life expectancy. But one of the things that happened to us is that early detection is so important. For me, is that I was fortunate that I had an advocate. And who do you think my advocate was? No, it was my mama. My mama told me, I used to go to Detroit every Christmas to be with her because she was 95 years old. And she looked at me and she said, son, something wrong with you. And I said, Mama, nothing wrong with me. She said, yes, something wrong with you. When you get back, you make sure you get checked. So I got back and got checked. I found I had prostate cancer. I was diagnosed on a Monday. I saw another doctor on a Wednesday. I saw the doctor at Vanderbilt on Friday. And then the doctor looked at me and said, well, I can't do surgery on you till 6 weeks because I'm busy. And I looked at him and said, my mama says I need to have surgery next Wednesday because the signs are right. And y'all heard the almanac, right? The proper time for growing crops and everything else. And he looked at me and started laughing. And he looked at his nurse making it rain. So he had 4 surgeries, and he put me on for surgery, for prostate surgery, at 12 o'clock, and he was finished by 1. And so what happened to us, again, my doctor, Dr. Caldwell, called him at Vanderbilt, got me in 2 days. It wasn't going to take place if they don't make that call. So many times for us, we had to be advocates for patients to get things done. And what happened is that I got the surgery. I had a low-grade surgery, and Valentine's Day this week was my 21st anniversary cancer-free. So what happened to us is that with prostate cancer, many of us has the myth that if I get surgery, I won't be able to, I'll lose my Well, you will, to some degree. But you still can, with the new technologies, you can take medications and everything else, you can continue your own life. And one of the things about it is that before now, you have to seek out a doctor who would do nerve-sparing prostatectomies, not people who says, I don't do that. If a doctor says, I don't do nerve-sparing prostatectomies, you should find another doctor, okay? And what happened to it, if you have that technique, one who are doing that technique, you have a good result. But also you may have incontinence, which can very be treated if you do certain things. You only have a low percent, 1 or 2%. 50% of people may have some trouble with impotence or erectile dysfunction, but within 2 years, it's improved. And also when you can use Cialis and other things for that, or Viagra, what happens is you can improve, or either you have implants. So what happened to us is that this is something that you can use that would basically allow you to have a normal functioning life. And so I think many times for us, we have to not be discouraged about prostate cancer. Early diagnosis, early detection, identified before it becomes stage 4. That means you must get PSAs. If you have a family history of prostate cancer, in blacks, you should probably start doing it at 30. When I had mine as a young man at 32 with having prostate cancer, okay? And so instead of being 50, you go back probably to about 40 to 30. And so what happened to us, the rule is an ounce of prevention, early detection, can save your life and also prevent a loss of problem. So I thought this would be something that would be very important for us to know, but most importantly, be an advocate for your patient. At this time, we open up for questions. Does anyone have a question they want to ask the panel? Dr. Shaw?
I was just sitting and listening to you and wondering what is the percentage of disparity between black men who go to a urologist and are told to have one type of surgery. Say somebody that doesn't know anything about a nerve-sparing procedure. Do you know, and I'm putting you on the hot seat, Dr. Mance, but do you know if there is a big disparity in the number of black men who have that procedure and those who don't? Or it's offered?
I can't answer that question, but all I know is that right after I had mine over the last 5 or 6 years, I've had several urologists that basically says, I don't do that. And the patient goes home and have the surgery. But most of the robotic surgeons now who are reputable, they will do nerve sparing. The key is, too, is that you have to seek one that are doing at least 100 per year, not one who says I do 5 or 10. And that's one of the important things to do. But another thing I also tell people, too, I have made myself available for if a person has prostate cancer to come talk to me. My rule for life, if I ask you, do you have a problem? I'm not asking you to be nosy. I'm asking you because in my life now, at 74 years old, I've learned things that can bless your life, and I'm willing to share. And I think all the panel is the same way. That's one thing we find about African-American physicians. They are very giving respect to if a person calls them and they have a question. Yes.
What about PSA numbers?
Okay. PSA numbers. Okay. Most of the PSA, as you get older, as you develop, all men develop BPH, the PSA kind of rise. But you have a number called 4. And what happened to us, one of the things that my urologist told me, which I read this over and over again, there's a trend upward. If a person has a PSA of 0.5 this year, next year they have a PSA of 1. Next year they have a PSA of 1.2. Next have 1.8. It's still within normal range, but it's inching up. That person is the one that you should think about getting a specific antigen, which will help distinguish. But then another thing too, my PSA went up to about 4, and I started taking lots of nutrients, and I went down to about 3. But it was still, overall, over the last 3 years, has been trending up. And so when I got my biopsy, I was very early detected. And so what happened to us, you have to think about PSA trending up. But if it goes high, it can be related to inflammation. It can be related to if you have any type of trauma or anything like that, BPH, you think about that. So sometimes you do a series of PSAs. You may do one this month and then repeat it in 3 months and see. The beauty of prostate cancer, most of the time, is slow growing. Every man at the time of 80, 90% of people have prostate cancer, but it's a slow growing thing. People who get the prostate cancer early are having more aggressive. But with the biopsies, they can determine by the Gleason score to see whether it's aggressive, whether they should respond now or not. But also with chemotherapy and radiation, if you basically get radiation and chemo, there is a divide in about 10 years with respect to survival. After about 10 years, the survival decreases with radiation, but increases, it's a little higher with surgery. But also, you have to remember is that for all the stuff we do, and which one of the things I always tell people, when a person is diagnosed with cancer, their body has failed to destroy it for 10 to 15 years. Their immune system has been deficient. Change your nutrition, change your lifestyle to make your system more resilient so that you would not get the second one. And that's the thing.
I was told, I don't know if it was your urologist who told me, that the difference between numbers for blacks and whites, that if a black male had a number of 2, you might want to start looking rather than a number of 4.
Well, 4 is
urologist
a
told me.
range. Is a range, but if you trend up, if you go from 1 to 2, then you start looking. Okay, it's a trend up.
Well, he was just saying the difference between blacks and whites, that if he sees a black man with a number of 2, then he's looking, rather than a white man. If a white man has a number of 2, he's not concerned. But if a black man has a number of 2, he's concerned.
Well, you may have heard that because my mind wasn't right at that time.
Dr. Williams, my question is by Dr. Williams. In our community, we have a lot of fears because of a lot of myths and so forth. How is it that you are able, and I have someone close, as you well know, that has metastatic breast cancer, how can you make us, this is Black community, more comfortable with participating in trials? I think we are so afraid, and if you get the placebo, so help me understand how you can convince someone, particularly when you have a relative who may not be doing well.
Yes. For me, when I see my patients that I recommend for trials, usually when we're recommending people for trials, it means that they have failed some type of therapy before. And so my way of getting them to try to participate or even think about participating in that trial is saying, hey, we can keep doing what we're doing, but you have shown that you have failed this treatment. And so what is it going to hurt if we do the trial? Now, yes, you do take that chance that maybe you will be in the placebo group and not actually get a benefit from that medication, but what if you're not? And so then that could change things. And the one good thing I have to say about breast cancer is that even though minority women and Black women are dying disproportionately, we are making very good strides when we talk about research for breast cancer. Now, we do have to close that gap, but the good thing is that the research does make a difference. And I mean, just 2 years ago, we've changed management within just the last 2 years, and we've seen a tremendous response in adding certain medications that we didn't do before. And so it is so important that we ask our patients to participate. And I think it's going to be more well perceived from somebody that looks like you than somebody that doesn't look like you. But it's something that I even have to try to convince people to do as well. And you just have to say, hey, this is what our options are, and this is what it could be. I cannot make them any guarantees, but I also say I'm not God. So, it's worth a try versus what we're doing, because what we're doing is not working. So either way, we're going down a path that's not working versus trying something different. And, I definitely think hearing that from someone like me makes a difference than hearing it from someone that doesn't look like you, that you may not trust. And I think as far as me and probably most of us up here, we have really good relationships with our patients. And my patients know that if I tell them something, it's something that I would tell my mother, I would tell my sister, I would tell my aunt. And I would not tell them something that I did not believe was going to benefit them.
Dr. Cleopatra Thurman, could you come up just for a second? She's going just like she was, Dr. McCoy talking about the time is hard. She's going to tell you time is the brain. And she's the new vascular head at Erlanger. Can you just give us a little brief step importance of the TPA and the clot busters?
Hi, everyone. My name is Cleopatra.
You can turn around so they can see you. Oh, you got a camera in front of you? Oh, okay.
Oh, so I can turn this way? Okay. So my name is Cleopatra Thurman, and I'm a vascular neurologist at Erlanger, and I'm the director of the program there. And when I heard Dr. McCoy say, time is muscle, I was like, he's definitely stealing that from the stroke world, because we always say, time is brain. So the faster that, you can get to the hospital when you're having stroke symptoms, and that blood vessel can be open with the medications that we have available or the surgical treatments, the higher your chances of recovery. And one thing that I want to share is that in my experience is that I have found that a lot of times African Americans and people of like the minority groups have a higher chance of declining even evidence-based treatments that we're offering. So thrombolytic therapy in the world of stroke really changed things, right? A long time ago, patients came to the hospital and the neurologist saw them in the morning, or the internist saw them in the morning and they said, yeah, you look like you had a stroke, your arm is weak and your leg is weak, and it localizes to this area, and there's really nothing we can do for you, right? But thrombolytic therapy really changed that paradigm. Now you come to the hospital, and it's the most amazing thing, the most beautiful thing to see a patient in front of you whose life was stripped away. You know, 1 minute they were in the grocery store with their family, the next minute they're down and they can't walk. Paramedics get them to the hospital on time, and you give them thrombolytic therapy, and you see their symptoms start to improve. Such an amazing thing. But every minute that goes by without opening that vessel, 2 million cells die. That's a lot of brain cells. So if I were to choose between a hospital that's going to take 1 minute longer to open a vessel and a hospital that's going to do that more efficiently, it's that important that if I was going to send my mother somewhere, I would choose the hospital that had times that were 1 minute better. And so I do want to take this opportunity to just give a shout out and you know, anytime that, you know, we can educate our communities about ensuring that when there's treatments out there that are tried and true, let's embrace them as a community. And I'm actually starting out some treatment trials, and the reason I had put up my hand and Dr. Mance called me here to talk about stroke care was really, I wanted to ask a question. You know, as a young African physician starting in this community, how do I reach out to the community to try and pull more people of color into our trials? Because I agree, there's about 14.2% African Americans in the United States. Only about 5% of those people are actually part of clinical trials in the world of stroke. That's a huge disparity, right? And if we're not part of the solution and we're not part of those trials, how will we ever find out if these medications and these treatments are actually right for us? So we have to remember that we're not an experiment when physicians offer us to be part of a treatment trial. It's an option to treatment, right? You need to take the time to understand what that benefit of that option gives you, okay? And I think there was a question that was asked earlier. Another important thing to remember when you're offering patients medications or to be part of the clinical trial, it's not always that you're going to get a placebo. Sometimes it's a clinical trial that is between a medication that's already available, the standard of care, versus the new medication to see if it's better. So be sure to be well informed about what this treatment option is that your physician is offering you before you decline it. So I think that's all I have to say.
Well, thank you. One more thing before, we have a new cardiovascular thoracic surgeon here. Dr. McLean, could you stand up and just say hello? You're new in town, I haven't met you, but I want to welcome you here. You can come and say a few words. No, you face me.
So my name is Michael McLean. I grew up here in Chattanooga. Went to school at UTC and med school in North Carolina. And I've been practicing out in Los Angeles for the past 13 years, cardiac surgery. So we're sort of in the transition of, interested in coming back to Chattanooga. So I haven't, made the commitment to come back full time. So Park Ridge Medical Center is where I met Dr. Love. So we're transitioning to see if it will work out coming back full time. So happy to be here. But I do have a couple of questions that I was going to ask.
Oh, you can sit down.
It's for the neonatologist, Dr. Spencer. So I came in on the tail end of your comments. There was a study a couple of years ago that came out about the infant mortality rate when the black babies are cared for by white physicians versus black, and it could be reduced by up to 60%. And I found that quite shocking. Can you talk a little bit more about what goes into that when a neonatologist encounters a newborn, premature baby, and what in the world could possibly account for that difference? Because you're both, white physician and a black physician are using the same standard of care supposedly, but that's a huge disparity.
Yeah.
And a question for Dr.
Oh, yes, no worries. I find that statistic very hard to even process. I think that a lot of times as African American or black physicians, we come with a lot of humility when we're taking care of our patients. So to think that that could even be a reality is hard to kind of fathom. And so it's something that, not my colleague and I, we saw the statistic and we talked about it amongst ourselves, but we were thinking it's hard to actually physically see. But I will say sometimes when it just comes down to giving patients a chance sometimes, I think. I know that right now we resuscitate babies all the way down to 22 weeks gestation. And the outcomes for those babies can vary. And sometimes people would think maybe not resuscitate or resuscitate in those situations. But I know personally I've sat down and talked with some of the black families that come in and talk with them about the situation and give them the options and have resuscitated those babies where their outcomes sometimes do better. I can't speak to it any more than that just because I haven't looked to it with any other depth, and I don't see anything that I can tangibly say when I'm interacting that I could say, I could see this is the reason, this is the reason. But I do think that culturally we bring a certain level of empathy to certain situations that I think it adds when we're taking care of the patient. So I think that helps a lot as well. And also listening to the parent a little bit when they're bringing certain complaints about certain things. Even in the intensive care unit, I work in collaboration with parents when taking care of babies, so I think that could really be another factor that's added in. But other than that, I don't know the depths of the intricacies of that, but I do think there are biases even in our NICU that are impacting our babies for sure. So.
I think the oldest position on the panel was a group in a rural area, and sometimes we saw cultural and self-imposed biases, where an older family member would go to the physician's office, and if it was a black physician, they would be less likely to receive that information than from a white physician. So you've been in practice long enough that hopefully you don't see that as much. Do you still see that as any self-imposed disparities?
Well, I really don't necessarily see it, but my life is I try to communicate with people. I'm a happy neurologist. I always tell people I'm a happy neurologist. And I try to communicate and relate to patients, and I think that's the key. But also I try to tell people about one of the things that I talk a lot about is nutritional support, because the old folks always said what you eat. And many of us apparently don't believe what we eat. What we eat. And so what happens to us, if we eat good nutrition, you will have a better outcome with respect to your baby, in pregnancy, with respect to breast cancer survival, with respect to diabetes, heart disease, all of this thing. And so I tell patients, you cannot expect to take a medication and go out and eat a Big Mac plus French fries plus a milkshake and plus double size, expect to do well if you basically bombard your body with all these toxins and chemicals and refined sugars. And so what happened to us is that I think many times for us is that most doctors, Western medicine doctors, don't really talk much about nutrition. That's just something that they don't talk about. But that should be a foundational piece that all of us should be talking to everybody. But I think black doctors, doctors who care, will try to communicate. But we got one problem now. Because of institutions that made it where a doctor has to see 50 people in so many hours, they can't spend the time to teach this. And then you have to do another thing too. You can hire a dietitian or someone to teach it, but then the thing is, who's going to pay for them? And so what happens is we have problems. But the beauty of this right here, one of the things I was telling my wife about is that they say the coronavirus mandate will be removed May the 15th. And I've heard this patient says, I'm so glad the mandate going to be removed, I don't have to wear a mask anymore. And I said, do you know what that means, the mandate removed? They said, I won't have to wear a mask. I said, no one has to mandate you wear a mask anyway. The mandate says the things you were getting free, now your insurance company going to decide whether they pay for it or not. The things you're getting free, now you're going to have to pay for it. So I think most people in America don't have no clue about removing the mandate means that they have to have more money out of their pocket to get vaccines or get tested or all these things. And that's one of the things that people don't really understand.
There's one color that it sort of is. It's all about how you grew up, what you came through, and I know what you're saying. One of the colors of this is that we've grown a different branch of medicine now. It's called the nurse practitioner group, and one of those issues that always confronts me in the office is that patients have always been seen by NPs, particularly for cardiology. And when patients, I was standing at the, never forget, fairly reputable tennis player who had a stent. And we were talking sports barn. And he had been on Plavix for 4 years. And I said, what? You've been on Plavix for 4 years for a stent? Usually now we take them off in 6 months. And that's the basis of knowledge of a person being on Plavix for 4 years, that your primary doctor could have taken you off and not created a problem, particularly intracranial bleeds. And I said to him, you really need to talk to your primary physician. So I say that to say this, one of the communications that we're having now, particularly in cardiology, is patients being able to talk directly to their cardiologist, their doctor. And that's making a difference in medicine. So I would urge you to really, when you're paying for those kind of things, be susceptible to making sure you get at least a glimpse from your primary doctor. Okay?
Dr. Sharp.
Go ahead.
You said something that is put a spark in me because if I take anything away from this panel, you have said that Black patients do better with a Black physician, that we need to be advocates for ourselves and our families.
Absolutely.
We need to put ourselves in more trials and be open to those. You know, we have our own biases, and our families have, don't get in that study that they're going to use you as a guinea pig. So those type of things. But how do we have gotten a lot of nurse practitioners, and Dr. Hubbard and I have been practicing for a while, and we'll have patients come up to us and say, well, I've been seeing Dr. such and such. And I said, well, we've been here for a long time, and we know all the pediatricians here in Chattanooga, and that is not a pediatrician. So we need to produce more Black doctors so that our community can see more people of color. We need to produce more nurse practitioners of color so that if you're going to see a person that is not a physician, that you are seeing a person of color that is a nurse practitioner. But how are we getting more Black doctors? I mean, where do we start? I mean, are we talking about doing things so that in high school we are encouraging Black boys and girls, and we are seeing less Black doctors, Black male doctors? More of the medical students now are female Blacks as opposed to male Blacks. So those are some of the disparities and some of the things that we need to think of. We have one that is in medical school now that was my baby. So those are the things that we like to see, encouraging our Blacks to go to medical school so that they can be the one when they look at you and say, I see you, I see me in you. Okay.
I may have misunderstood your question, but were you asking, have we still seen where Black patients still don't want to see Black providers? And unfortunately, that's still the case. I see it all the time. You know, my partner, she's white. And so people come in all the time and they expect to be seen by an older white female because they think that maybe her education was better than mine. Maybe because she's older and because she's white, she understands. And she is a better surgeon than what I am. But then also what I find on the reverse side of that is when those black patients are misunderstood by that white doctor, then I have to come in and I have to fix the situation. And so it's also, again, it's about educating our community that just because I'm black doesn't, I work just as hard as what the other person worked. And if I didn't have, you know, I have credentials behind my name, and if I did, they wouldn't let me just go to school and say that I wanted to be a doctor. So we also have to educate our community the importance and why it's important to see a black physician. Because I tell them all the time, and I promise in particular, I take very good care of all of my patients, but I tell my black patients, nobody will take care of you like I will in Chattanooga. And unfortunately, some of them are still learning the hard way, and they still will choose to go see one of those white doctors, but again, they all end up back in my office.
That was a question you asked me? I missed that question. I'm sorry. I'm sorry about that. That is true. And for some reason, well, I've been, well, it's still, well, look at this way here, is that people have a tendency to stereotype people, okay? I tell people, like for me, is that I laugh and talk with everyone. No matter whether you are a ditch digger or whether you're a nurse or whatever. I will treat you, I laugh and talk with you because my parents told me to treat everybody. Where I come from, everyone we met, we said, how you doing? Okay? Some people have an air which says that they feel that the other person, because he carried himself a certain way, this is not. Or they can find fault quick. I find myself with people, the people you do the most for are the ones who can complain the greatest. That don't stop me from basically committing to do the best I can for everyone. And so you will find that, because I know with my children born, the doctor who delivered my children, my son and daughter, his mother sent him to med school, and he come back for Thanksgiving, and she said, I won't let a black doctor touch me. And he said, Mama, you just sent me to med school. Why you say that? It's totally irrational. But for some reason, that is in their mind to some degree, and sometimes we have a tendency, and you have to overcome it. But one of the things I tell people, and Dr. McCord and I talk about it all the time, I talk to him, I says, you would not be here if you were not trained and competent and doing a good job. And when someone says something about you, I'm going to be an advocate for you. I'm not going to sit there and say, I think many times for us, we have a tendency to not become an advocate. And that's why I tell people the most important thing for all of us is relationship, relationship, relationship. Because if you know someone, you can trust someone. And that's the whole process that I basically live by, is that I want to have a relationship with you, because the rule is, the more you get to know me, the greater you should trust me. Most people in life, the more you get to know somebody, the less you trust them, because you start seeing their fallacies. But you want to make sure that you see someone who basically, you know, have your back. And that's what I think we all has exemplified. And I haven't done it for the last 40 years since I've been here. Yes, ma'am.
Yes. I live in a rural community, but I also work in Atlanta. I worked 35 years at Atlanta Medical Center, Emory University, Grady, and all that system, which Atlanta Medical Center just closed, so I'm moving back over to Emory. My thing is that, working in the Atlanta community, we see good gobs of African-American physicians. They're everywhere. My hospital, Atlanta Medical Center, I remember when I first went there 30 years ago, we rarely saw African-American physician, but everybody there just about is African American physician, except for the residents. And I've been a critical care physician assistant and a physician assistant and anesthesiologist giving anesthesia. One of the things that we had to teach most of the residents came through, lots of times were white, though we got a lot of black residents from Morehouse and from the non-traditional off-country schools. The black doctors would bring those in to train them. But one of the things we had to teach the white residents was respect for their students. I mean, for their patients. You know, don't refer to your patient as chief and all those things that they would do. And we, even our, of course, most of our staff became African American nurses and PAs and whatever, though we did have a lot of other cultures. But we had to teach them to, you know, the respect for their African American patients, because 90% of their patients were African American. And once they saw that we wouldn't put up with the disrespect, it changed the attitude. And I remember several times I had to write them up, and they said, "You're going to lose your job." I said, "Okay, I'll lose my job," but I never did. But I'm going to write so-and-so up, because you're going to respect these patients in here, and you're going to respect me without this type of attitude. So it comes a lot from us demanding respect, but in a nice way. And I feel that I hope there's a lot of people out in television land or wherever that's live streaming that are regular, everyday people. I wish we could still in our, you know, I live in a rural community where I do all my volunteer work, is that they still get their knowledge still basically from the church. If you want to get a crowd of just everyday people, do this forum in the church. They will come out. Because here, I think almost everybody's a doctor, and you're kind of preaching to choir. You need to preach, that they need to learn how that it's okay. Like, I remember my mama taught me it was okay, and she just had a high school education. Okay, to ask that doctor, she would say, "I know more about my body than that doctor." And she would tell the doctor really what was wrong, and ask the doctor what was wrong and everything. And then when we saw that that doctor wasn't sufficient, he was white and elderly, we changed to another doctor. He was white, excellent job. Listened to us, what our concerns were, what my mother needed. My mother got the surgery she needed after sitting there for how God long without getting her surgery. So sometimes it just takes an advocate who knows, because my brother and sister didn't know. And so they called me up, and I looked at her immediately and said, "Her hip broke. How long has she been like this?" And he said, 2 weeks. I said, "Okay, let's get up to Memorial Hospital." Who did I diagnose this? The local county hospital. I said, "We're going to Memorial right now." And the first thing they said, "Well, her hip broke. She should have had surgery 2 weeks ago." I'm going like, oh my God. See, they didn't know to advocate for her. So we need to teach the everyday person. And so I taught them how to advocate for mama, what they need to look for, and to call me more quickly. And so, and you do it in a nice way, but it has to be done. So we need to get out in the community and teach the everyday person what they need to look for, when they need to start having their PSA tests and stuff like that. I had to teach my husband. Now he's up on it. I had to teach him how to advocate for himself. He gets his lungs scanned every year because he smokes a cigarette a day, so he gets a lung scan every year. And found out all that was free with his insurance. Didn't even know it. So we have to teach them how to advocate for themselves, because they're scared. They don't know.
Thank you.
We do have a question from online from someone that's watching the live stream. They want to know if there is a directory of black physicians in Chattanooga where they can easily find black physicians.
Well, you can talk to Dr. Hubbard.
It needs updated. We do have one, but it has been a long time, and we have had several young professional board-certified physicians to move to our community. So it is, and we're going to use this meeting as a time to realize that it's an urgent need to update.
If you call your office, give them your office number, they can call your office, and you'll get that to them.
Okay, boss. 423-493-2100 and ask for Dr. Shaw.
Did you have another question? Do we have any other questions from the audience?
It is 423-493-2100.
Ask for Dr.
Dr. Hubbard or Shaw, we work together.
We do have quite a few that are watching online tonight, so we want to thank them for not coming out storm, but to be online. So we do have one more question. Let me pull that up. They've been sending me the text of the questions. It says, I am a white mother with an adopted black child. What steps can I take to ensure that he stays healthy?
Well, the first thing, she needs to make sure she have a good PCP, a pediatrician. A good pediatrician will be the first step, and before that, good nutrition. Stay away from junk food. Everything flows from the primary care doctor out. Most primary care doctors and pediatricians can take care of 95% of the things that they come in contact with. But the other 5%, when I was in my hometown, I went to my doctor. He was a white doctor in a little town. He told me, he said, son, what do you want to be? I said, I want to be a neurologist. He says, you will always be needed because we who are PCPs will need your expertise. Same thing with respect to Dr. Williams and the neonatologists and cardiologists and all the specialists, the thoracic surgeons and everything else. They are needed because what happens is that they bring to the table expertise that primary care doctors aren't trained to take care of. And they are specially trained to be able to do that, to give their expertise and get the best results.
Certainly, we'd like to thank the panel. Let's give them a big hand. I was hoping there would be more individuals, not doctors here, but because we're live streaming, I'm hoping a lot of people got to see this. This was wonderful. We need to do this more often. We need to talk about these things. Certainly, certainly this has been a great panel, and we certainly thank you all for coming out tonight, and we thank our audience and our other doctors for being here. Thank you all so much. Dr. Hubbard, thank you, because I know you work behind the scene to help put this together. Dr. Shaw, working with Dr. Mance, because we talked about this a few months ago. And certainly we really appreciate to the new doctors in town, thank you for being willing to come out and talk about your profession as a whole. So as we are about to leave tonight, we hope that you all will come back and see what we have to offer in the Bessie Smith Cultural Center and the African American Museum. Cannot get away without inviting you back to see what we have to offer. Okay, thank you once again, and have a safe trip home. I think it's maybe it'll stop raining right now.
It start raining?
I think so. Thank you again, Dr. Mance, for not allowing us to not do this tonight. Dr. Mance said, don't worry about the weather, we got this. Okay, so we appreciate that. Thank you so much. Okay. And thank the audience again. All right. Have a good night.